All right. Hello. There we go. That may be as good as any explanation we get. Yeah, sorry, beg pardon, sir. Yeah, thank you. You're okay. All right, ladies and gentlemen, I think we have our quorum present. It is 1:30 by my watch, so we are ready. I started to say we don't do casino gambling in Georgia. Well, let's hear the presentation before we hear your amendment. That'd be all right. Unless you want to strip the entire bill and just put that on there. I think it has happened before, maybe once. You'd like to come up and have a seat? You got, we got a, we got copies for you. He's got nothing with him either. Okie dokie. I think we did. All right, table mic is on. Let's see if we got the right LC that we're working off of today. You want to give us what you got, Chairman?
Yes, sir. We have LC 337012S.
7012S. So it looks like what we've got. All right, before we get started, do you have a sign-up sheet down front?
I did not.
All right, well, we'll ask for folks. I'm sure there'll be some people here. I bet there's people here that want to talk one way or the other on this bill. But we're going to limit discussion today. We're going to be out of here by 2:30. Okay, so if you got people who want to say yay or nay, if it's the same comments, we're not going to ask you to repeat everything that's been said before. All right, Mr. Chairman, y'all want to present the bill either or both, whichever way you want to do this. We'll leave it up to you now.
Thank you, Mr. Chairman, ladies and gentlemen, members of the committee. The substitute to Senate Bill 153, as the chairman mentioned, this is a full substitute of the substance of Senator Brass's Senate Bill 153, and he was, I've been told, okay with this. It's substituting the language from Senate Bill 221 by Chairman Renee Unterman in its entirety, and she's certainly good with that. It almost exactly mirrors the verbiage of House Bill 36, sponsored by Chairman Meadows and myself. This is a bill that, despite the significant wailing and gnashing of teeth you always hear on scope issues, a straightforward proposition. This is just very simply, this establishes a process by which optometrists are able to become credentialed, and that's key, credentialed and trained to perform certain injections into the eyelid and the mucous membrane of the eye. It doesn't allow them to perform injections directly into a globe. We can get into all of the differentials between the thin tissue and that kind of thing. Ladies and gentlemen, we have dealt with these scope issues year after year after year. Boil it down, it becomes, and they're going to stand on their head and say it doesn't boil down to the money, but it does. It boils down to who wants to do the procedure and who gets paid to do it. We have heard the Chicken Little cries of that the world is going to come to an end every time the optometrists, who are highly trained individuals, they sit in the same medical school classes. I've researched this for 30 years as the ophthalmologist. They do not perform the same operations? No, they're not surgeons. But the things that they're asked to do, the things that we've allowed them to do in their scope in this state, if you had listened to the screams and cries about what was going to happen after each one of these over the last 20 years, where we've allowed a change in scope, generally to reflect with what the other 49 states in this country are doing, you'd think that there would be malpractice suits all over the state against optometrists. There have not been. You'd think that the eye care of the state of Georgia's citizens was going to demonstrably fall off the edge of a cliff. That hasn't happened. Responsible, trained medical professionals like the optometry doctors that are in this room and all over this state to provide significant health care all across the state, but particularly in the rural areas of the state. They are well trained. They're not asking for anything that's not done. It's done in 14 other states right now. And you know what? Not one malpractice suit. Let me challenge the ophthalmologists who are going to come up here and ask them how many ophthalmological malpractice suits in that same cohort. You may see a wonderful picture of a bloody eyeball as a prurient exhibit here. That wasn't an eyeball created by an optometrist. That was an eyeball from an ophthalmologist. If you want to get into those types of games, I can pull up some great pictures of some malpractice suits on my phone of bloody eyeballs from those who don't want these trained individuals to do it. This is a straightforward proposition. These individuals are doing it in 14 states. It's not something that's going to harm the health or safety of any individual in the state of Georgia. The chairman and I wouldn't bring it if it was. So, ladies and gentlemen, this is a proposition that adds to the health care choices and the capacity of the people who provide health care in this state to bring quality eye care to the citizens of the state of Georgia. Mr. Chairman, that's my statement.
Thank you, Mr. Chairman, members of the committee. Just a couple of things. I'm hit on that Earl did. We have been diligent to accept amendments to this plan. It has been amended, and I don't want to say to death, but we've agreed with almost everything that one side wanted. We weren't even able to get our amendment introduced in the first hearing. The second hearing was somewhat shaky itself. Optometrists, ophthalmologists go through the same classes to a point. And when they go to school, this is covered in those classes, regardless whether you're going to be an ophthalmologist or an optometrist. When you graduate and go into business, the wall is there. You can't do this. Even though we let PAs do it, we let dermatologists do it, and yes, they've gone and continued their education, and it's in here to continue your education. But better still, if you want to see bad stuff, we let people tattoo your lower eyelid. And nobody's trained them in any of this stuff. Again, no shots into the eye. There's a thin membrane over your eye that they get between that they can put some of these medications in. There are a lot of optometrists and ophthalmologists that are in business together. I don't think we've heard from a one of them. That means to me that both sides should be pretty good. There hasn't been a scope change for optometrists. I've been down here 13 years and I hadn't seen one. This is not a precursor for something else that we want to do in the future. It's to give those optometrists that are willing to go back and get continuing education the opportunity to do just what's in this bill. And for the life of me, again, Earl said, we wouldn't bring a bill that's going to hurt a bunch of folks. With that said, I'm willing to listen to any questions and try to answer them. I'll have to get somebody to answer them for me. But if you've got questions, we'd be more than willing to listen.
All right, any questions of the committee at this time? I know there's a bunch of people that want to talk on this, so And I don't have a sign-up sheet. We're not thinking ahead far enough. I'm sorry for not doing that. Who all wants to talk on this bill out there? There's a sign-up sheet there. We did have one down there.
It's empty.
It's empty, yeah. Okay, we forgot to tell you to come up and sign it. Sorry, that's our fault.
Why don't we
All
just
right.
we can just not let them talk.
Well, I want to hear a few. Thank you, Mr.
I'm
Chairman. I
just- I'm
appreciate
just
that
saying.
observation. Yeah, you're just saying. But y'all can sit there, gentlemen, and maybe help us answer questions. We got the podium, Mike. I do have a question. Number 24 is, okay?
Thank you, Mr. Chairman, and Mr. Chairman, and Mr. Chairman. I've received a fair number of emails from optometrists, and I don't know if everybody else's internet was down for the last 2 hours, but mine was, so I'm looking at this on my phone. But one of the things cited by the optometrists is that if they, well, one says they would like to perform this procedure as if it's just one procedure. What procedure are we talking about here?
Specifically, they may administer pharmaceutical agents related to the diagnosis or treatment of diseases and conditions of the eye and anexa oculi by injection. And then that's a series of treatments. I can't get into every medical protocol with respect to that, but what it does, it's as Chairman Meadows described, it's that under that membrane, there are certain pharmaceutical agents. It specifically excludes, and then after the comma, all the injections directly into the globe of the eye.
But is this procedure an injection? When you describe going between membranes, it sounds like you're slipping something in there, but are you puncturing tissue with this injection?
It is an injection. It is a needle. It does go under the tissue. I don't know whether or not that's semantically constructed as a puncturing of, it's not puncturing of the globe of the eye, because that's specifically accepted. It is an injection in that area in between. I'm going to defer to,
Okay.
you're going to have a chance to have some of the medical professionals here that can talk more specifically to it. But the one piece of that I do want to, Representative, is to say that not only are optometrists being trained currently in schools, in their schools all over the country to do this now, they have been doing it in 14 states currently without
Right.
any problems. Just to point that out.
Thank you. And one other thing in these emails, it said that allowing optometrists to perform this procedure or these procedures would result in a decreased cost. Can you explain that? In what way would our societal medical costs be decreased if optometrists were allowed to perform this procedure?
I've never made the cost argument with respect to this. That may be coming from an individual optometrist. I don't know what the overhead cost differentials between an ophthalmologist office and a optometrist office are. I would assume that perhaps a surgeon's office has more overhead, therefore the cost may be. I don't know the answer specifically to that. I do know that the access issue is less cost if you have to drive. I know we've seen maps provided by both, but if you have to drive a couple hours to be able to access a surgeon whose time is generally significantly busy, to be able to access this type of eye care, then that could add to the cost for our rural citizens.
One more question. Do you know whether an optometrist and an ophthalmologist is performing the same procedure, something that would have the same billing code, for example, for Medicare, the CPT code? Do they have the same fee schedule? Is the optometrist billing and getting paid the same thing as the ophthalmologist for the same CPT code?
I would assume for CPT codes that they'd be exactly the same. I was talking more about private pay differentials and tangential cost if you had to drive to get there.
So we're
Again,
talking about cost of getting to care that may be more remote. Okay.
That was my assumption. I'm trying to be responsive. I just not having known. That's not an argument I've made or
Okay.
we've made for the bill.
Thank you.
We may find out more about that in a minute. We hear some testimony. Let's try to limit these questions till may get some answers made there. I got two more that's lit up now. Representative Hawkins.
Representative Earhart, is this the same bill as the House bill? I apologize. I've been trying to bring it up, and the internet's down, and if you said so, I missed it. I can't hear and read at the same time.
There's some changes. It's very much like the original House bill that you've seen.
Uh-huh.
It's much more specifically Senator Hunterman's Senate Bill 221. It's still Where it's the same is where they may administer the agents inside that and under that membrane. Where there is some difference, they've added to the training requirements. It's now 30 hours approved by the board, and the supervision for that training is done by a ophthalmologist rather than an optometrist.
And I know that you added or excluded some medications. Is that the same that's in this bill?
Yes, that's in section, line 30, section 2.
Yeah, I just wasn't sure if they were the same.
It is.
Okay.
Nothing's changed in that.
All right.
Thanks, sir.
Yes, sir. Chairman Rogers.
Thank you, Mr. Chairman. Representative Earhart, or Chairman Earhart, you were talking about the cost savings a little bit, about the travel aspect and whatever. Kind of brings up something that I guess is dear to my heart, and Chairman Meadows may be better equipped to speak to this because it deals with the rural healthcare aspect. Can y'all talk about that just a little bit as to the impact this may have on rural healthcare?
I'd defer to Chairman Meadows on that. I live in a metro area.
That's what I was saying. I think he might be better equipped than Cobb County, but because he's in an area similar to mine.
Throughout more rural parts of the state, there are not a lot of ophthalmologists.
Would you get up in the mic so everybody can hear you there, Mr. Chairman, if you would?
I said throughout most of the rural part of the state, there's not a very large number of ophthalmologists. And the reason for that is they're going to concentrate towards where the highly populated areas are. The more population you've got, the more chance there are that there's going to be somebody with a problem. If even in my small town, we do have a couple of optometrists. I don't think any of them will do this. But given that there are optometrists out here that are willing to go back to school and get whatever continuing education they need, it won't do anything except provide a little bit more service to those rural areas where right now they can't get it.
All right, I got your question, sir. All right, anybody wishing to speak would come to the podium mic over here if you would. And I saw a hand come up, sir. I think you were, who wants to come up and speak? Y'all, don't be shy.
I was going to speak against it, and if it's my turn to do that.
Yes, sir, we're just gonna, anybody that's gonna speak, I need y'all to sort of line up over here, and if you would come up to the mic, sir, pull it up and give your name, position, and, yeah, whether you're for or against the measure. We've turned the podium mic on, I think, now, sir.
Yes, and thank you. Thank you, Mr. Chairman and committee members, for the time to speak. My name is Steve Walsh. I'm an anesthesiologist in Roswell, Georgia. I'm also the president of the Medical Association of Georgia, representing physicians across the state in all specialties and practice settings. I oppose Senate Bill 153. I believe the legislation, albeit well-intended, could place thousands of Georgians at risk of blindness and other serious eye complications. This legislation would allow optometrists to make injections and perform other delicate procedures in and around the patient's eye or eyelid, procedures they simply have not gained the experience and training to do. I understand this is a proposal to increase the scope of their practice. And increasing the scope of one's clinical practice is grounded in supervised clinical patient experience and training. This is what we call a residency. Scope should not be gained solely through a legislative experience. You know, we often face scope issues as an anesthesiologist, particularly with physician assistants and APNs. And Senate Bill 153 is different. With physician's assistants and APNs, they continue to work with the supervision of a physician. This is different. The optometrists who want to broaden their scope also want to continue independent practice. I applaud the optometrists for the role they play when it comes to eye care. Optometrists have been trained to detect serious eye health issues, and they fit patients with glasses, contact lenses, and other similar corrective vision devices. But Sticking a hypodermic needle into or near a patient's eye requires a level of experience that should be reserved for physician specialists who have the requisite and far more considerable education and training experience. And when I think of today's patient population, I also recognize there is an increasing amount of patients who are on blood thinners like Coumadin, and we've seen the commercials, Pradaxa and Eliquis, as well as others. And these are truly a risk when you consider injections. Blood thinners and injections can lead to hemorrhage. Hemorrhage around the eye is a risk, and in some cases may require an emergent surgical intervention. So this is why optometry, providing injections as an independent practice, simply puts patients at risk. I am an anesthesiologist, and I perform injections daily. These procedures, they place needle tips close to the spinal cord, arteries and veins, lungs and other organs. But even with this skill set, I want you to know that I do not place injections around the eye. And when I have placed injections around the eye, it was only when I was working on site with an ophthalmologist at my side. An injection around the eye, as I mentioned, has serious risk. So for this reason, I refer patients and their families requiring injections to my ophthalmology colleagues for their expertise. And quite frankly, I believe optometrists should do the same. So for these reasons, I believe this legislation is a serious threat to patient safety care, and I urge you to oppose Senate Bill 153. Thank you.
Thank you, Doctor. Any questions for the doctor? Thank you, sir. All right, who's next? I got a slideshow.
Yes, sir. Good afternoon, Chairman and committee members. Thank you for being here and having me. My name is Dr. Brian Kim. I'm a medical doctor and an ophthalmologist. I've been in practice for 10 years in Dalton, Georgia, and I am also the president of the Georgia Society of Ophthalmology. I stand here before you as an expert eye injector. I've performed thousands of injections, procedures, and surgeries, and so from my position, having done this with a lot of experience, I think it's dangerous to have optometrists who have no experience doing this to inject needles around the eye. If it was needles anywhere else, that might be different, but with the eye, you only have two eyes, and if you injure it and go blind, you can't go back. So this is a quote from optometrists in a letter we've seen. Currently, there are medications administered via injection to treat papillomas, chalazions, and epidermoid cysts. So this is not true because papillomas and epidermoid cysts are never treated with injections alone. They're like skin tags, and they're not cancer, and they're never an emergency. The way you treat these is to inject it with a numbing medicine, and then you snip it with surgery somehow with a scalpel or scissors. And as you know, this would be prohibited by this bill. What concerns me if these folks are thinking that these lesions should be treated with an injection, then many Georgians are going to be at risk for getting unnecessary injections. As far as chalazia, they're basically a clogged oil gland on the eyelid, and it creates this little lump. Most do not need an injection or surgery. You can apply hot compresses, and the heat actually helps open up the drain, and it just goes away. So these are not emergencies. The optometrists want to inject steroids into these chalazia. Steroids are made of tiny little crystals, and when they go into the artery to the eye, it can block the vessel and cause blindness. So these tend to go away on their own, and if you inject them, they can cause blindness. So I really ask, what is the purpose of this bill then? This is another quote from the optometrist. Students of optometry are currently being trained and tested on the ability to perform injections and have received this training for many years. They claim extensive injection training, but do you know what that looks like in optometry school? And this is true because I've talked to optometrists about this myself face to face. This is the experience and training they're talking about. They're injecting a rubber arm, not real people in optometry school. Now, they inject dummies in school to pass their board exam. That's just part of their curriculum. They don't have any hands-on experience injecting real patients or injecting real drugs. In contrast, ophthalmologists who are in training do perform eye injections on real patients with real drugs. So another quote, this bill would require all optometrists to complete 30 hours of additional injectable coursework if they are interested. So this is misleading because it makes it sound like 30 hours is enough training. This is in a classroom. It's not in a clinic. It's not in surgery. It's not on real patients. They look to one another and say, you're taking this class, I'm taking this class, let's inject each other and we'll get a certificate. The injection is with saline, which is salt water. It's not real medicine. So there's no hands-on training during this class on real patients or real drugs. And a 30-hour class, I'm sorry to say, it's not like the 19,000 hours an ophthalmologist spends in training. So I agree. Like I said, I have great optometrist colleagues that I know, and they are very well trained, but not for eye injections. There's another quote. Optometrists study the eye during 4 years of optometry school, but ophthalmologists only study the eye during a 3-year residency. Therefore, optometrists have more years studying the eye. So this is also false and misleading. I don't want to get into the numbers, but I feel like I have to because that's actually been brought up. 4 years of optometry school is 2 years, first 2 years are in class studying about the eye. The last 2 years are seeing patients in clinics, but they're not doing any procedures or injections on patients. Ophthalmologists have to go to medical school first. So the first 2 years are all bookwork in a classroom also, but we're studying not only the eye, but the entire body as well. The last 2 years are seeing patients in clinic, but we are at that time also learning to do injections on real patients, IVs and various things. So we're getting some procedural experience. After that, we have postgraduate or after graduation training that's mandatory. Optometrists don't. We have to go to a 1 year of internship where we're seeing patients and doing real procedures, general procedures and general surgeries on patients. 3 years of residency after that is focused solely on treating the eye. So we're doing eye injections, surgeries, procedures, and treating various disease processes. They are not experiencing any of that training in optometry school. So hands-on, 2 years in school with no required residency. Their last 2 years, they do have hands-on experience with patients. But again, no procedural or injection experience. Ophthalmologists spend the last 2 years in school injecting real patients. Ophthalmologists 1 year in internship with doing general injections and surgeries. Ophthalmologists spend 3 years in an eye residency performing eye injections on real patients. So that's more than double the years. But as I was saying, this is very different the way those years look like, contrary to what you've been heard before. So again, optometrists should be proud of their training. Like I said, they're an important part of the eye care team. Our optometrists in my practice, I have 3 amazing optometrists. We're going to be hiring another one next month. They are amazing. And they're highly skilled and excellent doctors. But even they, and I really think most, don't think this is a good idea. A 30-hour class is not enough. And they've even told me, even if I wanted to do this, I would like to spend a lot more time doing this and being mentored on how to do these procedures versus just injecting each other with saline. Now, the same people who are proponents for this bill are also the ones who oppose this bill. Back in 2005, there was a name tag bill that required doctors to state their training on a name tag explicitly. And it was introduced to help educate patients about their doctor and to protect them from false advertising. Optometrists opposed this and got themselves out of this bill. Now, I mean, they should be proud of their training and show their credentials, but why did they want to be exempted? If you Google optometric physician, you'll see hundreds, maybe thousands citations. Optometric physician is actually an oxymoron, because unless you went to optometry school and medical school, you're not a physician, because a physician is a medical doctor. And so this is really a violation of the Medical Practice Act by using this label. The point is, many patients are already confused about who their eye doctor is. But the fact is, this actually makes things even more murky and more cloudy and more confusing. But y'all are not confused anymore because we've gone over everything now. So please don't be confused. Optometrists are not medical doctors. They have no training or experience injecting real patients or real drugs. They will be injecting patients for the very first time after this 30-hour class. And I think that's really sobering. No patients deserve to be injected by a beginner or to be a guinea pig, to be honest with you. No patient should be deceived. And what I mean by that is they should know that this doctor who's going to inject them has many, many years of training. Patients deserve the best quality of care and not cutting corners. Please protect the patients of Georgia and vote no, please. Thank you for your attention.
All right, any questions for Dr. Kim? Now, let me ask, the two, I guess, these were particular diseases that you were referring to, the papillomas and the chalicia?
Yes, sir.
Is that an individual disease
It's just a
That
type of growth.
type of growth on
Yes,
the
sir.
eye?
They're,
Okay.
yeah, they're not cancers or anything dangerous.
Okay. All right, I thought I saw a light light up. Did it go away? Okay. All right, doctor, thank you
Thank
very
you.
much. Who's next? Yes, sir.
Good afternoon. Thank you for a few minutes of time. My name is Paul Ajami, and I'm an optometrist. I'm proudly wearing my name badge that says OD and wear it every day at a referral center called Omni Eye Services, where I work with ophthalmologists and have since 1982. Our ophthalmologists are in favor of this bill. There are many ophthalmologists that really don't have the opinions that you'll hear today. It is kind of sobering if you listen to Dr. Kim about our education and other facts, except that he's never been through optometric training, no more than I've been through ophthalmology training. And so a lot of those statements are not only wrong, but fairly offensive to a group that has proven over and over again that, number one, we're an independent profession. We have our own board. We don't have oversight by medicine. We've proven that we don't need it. And as has been pointed out by our chairman, malpractice rates some of the lowest in the country. And really that PowerPoint presentation has been given over and over again since 1982, when I moved to the state and heard that diagnostic drugs, the drugs that dilate people's eyes and allow us to numb the eye, were going to, quote, cause blood running in the streets. None of that has happened. From there, we had a topical antibiotic and steroid bill. From there, a glaucoma bill. From there, an oral narcotics and oral prednisone bill. And none of these things that are predicted have come to pass. So we're very, very proud of our training. It's not true that we stick needles in rubber arms. At Southern College of Optometry, they have 2 years of training actually on real live patients. And I will agree with my colleague, Dr. Kim, that there aren't 10 or 15 patients coming in every day with chalazions that need to be injected or uveitis that needs a subconjunctival injection. But when a patient needs it, and it's on a Saturday or a Sunday or an evening or even during a week, and they're faced with an hour drive from Lithonia, Georgia, whether it's urban or rural, or they're faced with an hour and a half drive from wherever it is, Macon to the next biggest city that has someone that will see that patient for that. These are patients that need that at the point of service. If you use that same argument, then we should revoke the oral narcotics that we've been prescribing since 1992. I only prescribed for 2 patients last year for oral pain medication, and the argument was you hardly ever do it, except both those patients were at 3 a.m. on call, and they needed it. They were in severe pain from a corneal abrasion. This is just a natural extension of the drug delivery methods that we already do that I just outlined. The training is in place. let's put the 17 to 20,000 hours of medical school training aside to our 1,000 or 2,000 that we continue to hear, because that's apples to oranges. They're surgeons, and I hope they have 20,000 hours of training, and I trust them, and they're good, and that's where I'd go for eye surgery, but they're being trained in surgery. Injections are being done by DOs, dentists, LPNs, RNs, nurse practitioners. We're the only prescribing profession in Georgia left that isn't doing an injection. For goodness sakes, patients are injecting themselves. I injected my wife with infertility drugs for 2 years without 20,000 hours of training. And the question then comes up, well, that's not the eye. We work around the eye. That's what we do every day. We dig foreign bodies out of the eye. We go under that conjunctival tissue to take out foreign bodies, to lance cysts. It's something that we do every day. It's our profession. And if we did it irresponsibly and recklessly, like is always portrayed, none of us would have licenses and none of us would have jobs. Finally, the access issue, as I mentioned, is not just important as far as how far a drive you have, but how quickly you can get in to see a doctor. And there are doctors in this room where if you called them, they don't take new patient appointments. Or if you're an established patient within their practice, it might be 3 or 4 months before you could get in. Optometrists are accessible, easy to get into, and when the patient needs these limited procedures, and if an optometrist wants to get this additional review course, which is not the end-all be-all of training, we've already had it in school and in everyday practice, then they'll choose to do it and they'll allow that access for their patients. I would yield for any questions in the interest of time.
All right, Paul, you have a question, number 25?
Thank you, Mr. Chairman. Can you speak to the 30 hours of required training? The one option is to go to an injectable training class. Where would you go to? Where could I go get that training?
We will have to put it on. It will have to be organized for the state and put on.
And the other option is to under the direct supervision of a physician. So in the injectable training or physician, who's doing that?
No, a physician will be involved in the training course is what that means.
And it's 30 hours.
And it's 30 hours.
Is that adequate, you think? Or
It's a review course. It's very adequate. We've already had the training. Yes, sir.
All right, any other questions for number 24?
Thank you, Mr.
Yes,
Chairman.
ma'am.
Doctor, are there any procedures you currently do where you're licensed to puncture tissue?
You know, there are things that come up every day related to foreign bodies in the conjunctiva and the cornea, so the answer is absolutely yes. I had a patient last week with a piece of metal that had been sitting in the eye for a week, and so we take an algae brush and a needle and pull out the metal and then puncture the tissue and go into fairly deep layers, deeper than what we're talking about with the conjunctiva. So we do that every day. We've done it for 30 or 40 years in this state.
But you're using those implements to get something out, not to introduce something into the body. Is that correct?
That is correct, but we're introducing things into the body every day by using eye drops and oral medications that get into the systemic system versus just applying it locally where it won't have any of those systemic effects to other systems.
Thank you.
Okay, thank you. 22.
Thank you, Mr. Chairman. Mr. Jamie, is that right?
Jamian.
Jamian?
Yes, sir.
So to follow up on Representative Beskin's question, so are there injectables that might be a better treatment than an oral medication with less side effects?
Thank you for that question. Absolutely. And when this sty, for example, and everyone's known someone with a sty, medicine is portrayed during this session that all styes or most styes go away and it's just not a problem. Some don't. And in their own literature, I pulled something this morning from the University of Iowa, which is a huge ophthalmology program, where they talk about a very legitimate drug delivery system before you go slicing someone's lid to drain that sty, is to inject it with a steroid locally. It's from the ophthalmology literature in this country to the British Journal of Ophthalmology to websites of big programs. It's a legitimate drug delivery system. Is it done every day, 10 times a day? No, but when it's needed, it's needed. You have a 15-year-old that won't let you come near them with a scalpel unless you put them under general anesthesia. That's a patient that you could deliver this steroid, this little bit of steroid, into the inflamed sty and have a chance of shrinking it. Sure, if it doesn't work, then they'll need to be put under and incised and drained. But again, saving time, you talked about cost, saving an extra visit, an unnecessary visit. Again, if that doctor's comfortable. There are a lot of ophthalmologists that aren't comfortable doing retinal surgery. They refer it to a cataract surgeon. There are a lot of ophthalmologists that aren't comfortable doing anything but primary care like optometrists do. They refer all their surgery to us. We get referrals at our referral center for cataract surgery, one of the basic procedures that most ophthalmologists do, from an ophthalmologist. So it's all comfort level and using common sense and knowing that your license is on the line and acting responsibly like we have a track record of doing.
In your current, if I may continue, Mr. Chairman, in your current practice and license and ability to do this, you mentioned Lance earlier, so you are currently, it may not be, to your point, a puncture, but you are cutting tissue.
The lancing of the chalazion, if the injection doesn't work, is actually an incisional surgery that is not in our scope and it's not in this bill. But we do lance corneal tissue every day by cleaning up abrasions, taking out metal that's deeply embedded in the cornea, et cetera.
And I would think, too, the point with access and cost, if I have come to see you for a particular issue and you determine that the injectable is the preferred treatment, and today you're not able to provide that treatment, then the cost of a second appointment and a second evaluation and to receive that care, it will certainly add to the cost and the delay.
Family
and the
taking time off from work, et cetera, yes.
And then finally, I guess the final point I would ask, and I think you already answered this, you listed a number of non-physician, non-MD practitioners that provide injections today. I believe pharmacy even is looking over the last few years in this area. But there are a number of non-physician, non-MD practitioners that provide injections and have been doing so for a number of years. And the issue that I have seen is that the delivery of care in this state that is so diverse from rural and urban and access, the scope of service debate that we hear all the time. At the end of the day, I think the most important thing we are challenged with is providing a safe environment where access to care is readily available throughout our state where the citizens need that. It seems to me that your testimony is that your profession is receiving training and education, that you'll get the refresher on these procedures, and that the availability of that access to safe procedures for the citizens of Georgia is the motivating factor for bringing this measure. So you are seeing patients that you believe benefit from treatments via injection in your practice today. Is that correct? And how are you seeing that marketplace changing where you can provide that care going forward?
It's beautifully put, what you stated. I couldn't say it better. The other thing that I'd add is that the students in school now are probably going to be looking at, and it's not going to be me, I'm a few years away from retiring, are probably going to be looking at drug delivery systems that we don't even know about now. Microneedles, for example, where you have depot injections of glaucoma medicine that will sit under that thin conjunctiva tissue that sits over the white part of the eye to help with compliance and, again, cost. I had a glaucoma clinic this morning, and half the patients don't use their drops, can't afford them, can't get them into the eye. And so there are a lot of things that we're doing this, a lot of reasons we're doing this for the future. Sure, there are going to be people that don't want to do it and don't feel comfortable doing it, and they won't do it. They won't take a 30-hour course because they don't feel that they have enough training. But again, to portray us as an irresponsible group that's going to take a weekend 30-hour course and think we're comfortable with no previous training is really offensive to all of us.
You have two more questions, sir, or maybe another one. I'm gonna take them in order when they popped up. Number 29.
Yes, sir. I heard them say in medical school they were doing injections into a rubber arm. Do y'all not use cadavers in medical school anymore?
In optometry school, the trend has been that most optometry students work on a cadaver.
Right.
And of course, that started with medicine, but absolutely.
So you actually have experience doing an eye. Where did you go to school? Could I ask you that?
Absolutely. The New England College of Optometry in Boston, Massachusetts.
And they taught you this procedure there?
We were exposed to it back then, but that was 1980 that I graduated. A lot has changed since then. We weren't trained in the use of dilating drops that, again, ophthalmologists said would kill people, and all that's done is open up the pupil so that we can see disease and send them more cases. So, again, this just over and over again of how we're going to harm people with, one scope issue after another just hasn't come true. Do we want to keep asking for these things? No, but we're a legislated profession. They don't have to ask when a brand new laser comes out that they had no training in school, and the sales rep teaches them how to do it in the office on a couple of cases, and then they're an expert. So, we certainly are a responsible, independent profession. We've proved it over and over in this state and all 50 states across the nation.
Could I carry on, Mr. Chairman?
Yes, sir.
If you're an ophthalmologist, optometrist, and there's something wrong with an eye, is there not such a practice as called a retinal specialist that you would call that person in that an ophthalmologist may say, whoa, I'm uncomfortable. I won't go there. Let's get this specialist.
It's an excellent point because now most retinal specialists deal with a lot of diseases that used to be lasered or dealt with by surgery with injections actually into the globe, into the eyeball, with something called an anti-VEGF drug. And there are 40 or 50 injections a day being done in my retinal practice and in most retinal practices. Most general ophthalmologists or non-retinal specialists absolutely would never stick a needle in the eye, no more than we would. But there are PAs and nurse practitioners in several states that I know of for sure and have confirmed that are doing those injections. And when we say side by side, they're probably in the same office at the same time as the retinal specialist, and that's a good thing. But people can be trained to do things even if they're not in medical school. And thank goodness we have all the other health professions that are independent professions that aren't extensions of medicine but work with them.
One more question, if I may.
All right, quickly, we got
Okay. It's
run out of time here.
if you allowed another doctor, optometrist to do this in your eye, then you would have confidence that they could do it in a patient.
Absolutely.
Okay.
All right, thank you, sir.
Thank
Rest
you
of the
very
questions
much.
dropped off. How many
Thank
more
you for
people
your
want to
time.
talk? All right, yes, sir, come on up. Thank you, sir.
Mr. Chairman, I'm gonna have to step out.
Okay.
Thank you for your time.
Could one of y'all stay?
I got 8 minutes.
8 minutes. Let's see what we can do here in 8 minutes, see what's gonna go on. Yes, sir.
Mr. Chairman, thank you very much for the opportunity to say a few words about this bill. My name's Baker Hubbard. I'm an ophthalmologist. I've been practicing ophthalmology for 19 years. I've been training young doctors how to do some of the procedures that are considered in this bill in my role as a professor at Emory School of Medicine for the last 17 years. I want to make it clear that I'm speaking here as an individual. I'm not speaking on behalf of Emory University. I do work with optometrists. I have great respect for the field, but I strenuously disagree with them on this bill. And let me just tell you a little bit about why. If you'll direct your attention to the photograph down there at the end of the room, what you'll see is an eye. And then here where this double arrow is, you see those double arrows on the eyelid? That's a chalazion. That's a bump on the eyelid caused by granulomatous inflammation in the eyelid. Most of these things get better on their own and don't need anything done about them, but a few of them do need some attention. And when they do, one of the options is to inject them. And this patient had an eyelid injection done exactly like the eyelid injections that are described in this bill. It was done by an ophthalmologist. It was done over 100 miles from Atlanta, and they had a complication. And the reason I'm telling you about this is because I want you to know that eyelid injections can have complications, even when someone does it that's had 17,000 hours of training, they can have complications. And if someone tells you that they're going to be doing injections and not have any complications, they're either naive or inexperienced, or they're trying to mislead you, because there will be complications. Our field of medicine is very analogous to aviation. In the aviation field, we do everything possible to avoid plane crashes. This complication that you see here is analogous to a plane crash. The 17,000 hours of training is to minimize these complications. If you let somebody do these things that's had 1,900 hours plus an extra 30, there are going to be more plane crashes, more people getting injured.
All right, thank you, sir. Anybody else?
I have a few other things, but if I need to stop, I will.
Yeah, we got a few more people to talk.
All right.
Thanks, sir. Representative, you up?
Thank you,
Hold on,
Mr. Chairman. I'm going to be very brief. As you guys know, I'm a practicing optometrist. I've been practicing for 22 years, 18 of which have been in the state of Georgia. My background is I have a optometry degree from the Pennsylvania College of Optometry. I graduated in 1994, MBA from Wesleyan, and a master's in public administration from Harvard University. It has been one of the most disingenuous dialogues I've heard, specifically from Dr. Kim, around the training that has happened. I love public debate, I love public health, but let's make some things very clear. When I got into optometry school, the first 2 years of our optometry training centered around clinical diagnostic procedures, subjective exams that you do based on pharmacology, pathology, and we do those things for 2 years. We start looking at patients in our first year. This was in 1990. And we go for 4 years looking at patients in and out of clinic. So it's a bit disingenuous to say that we only have, sort of 30 hours of training. Once we get out of school, you have an option to do a residency. Whether you do it or not is your choice. I chose not to do a residency, but I did my rotation at Johns Hopkins Hospital in Baltimore, Maryland, which is where I'm from. Having said that, there has been an occasion in the last 6 months, actually there have been four times in the last 6 months, that I've actually done an injection on a chalazion. 4. You know who I did it on? My mother, who received antibiotics from a doctor in Baltimore, and she said, "Jake, this thing won't go away." I said, "Well, I'll come up there and I can put an injection in your eye. It'll take a quick second, and we'll see what happens. Well, I did it, and it went away. Second, my son Jacob, 17. Y'all might have seen him running around the Capitol. I did it to him in November. For some reason, he had a Shalazen. I didn't even know this bill was going to come up. And I said, look, come on into the office. We have these needles. I'll do that. And then this is going to shock you. I know you're going to believe this, but it's absolutely true. I have no reason to lie to you. The last 2 people I did it on, myself. I took a Shalazen clamp, flipped my lid, took a 27 gauge needle, which is about a 1/4 inch thick, injected myself with triamcinolone, went away. So to say that we don't do it is just false. And I wouldn't even provide that testimony, except I keep hearing that we're providing these injections on arms and not people. I did on my mother, who I love, my son, who I love, and myself, I certainly love. And so with that, I'll yield.
Wait, just a minute, Dr. Beverly. Now, you are a
Optometrist.
optometrist.
Yes, sir.
Okay.
Okay.
Not an ophthalmologist.
Not an ophthalmologist. I have tremendous respect for him. I refer a ton of folk to him all the day. And as a matter of fact, I have a private practice, eight patients. I treat glaucoma. It's a pretty, if you guys ever want to come, you'd see it. It'd be
Eight
excuse me, eight
I started to say you
eight
have more than
employees.
patients.
Yeah, I'd be broken. I wouldn't stand up here right now. But anyway, if you guys have any questions, I certainly could
Y'all
answer
got
those.
any
but I
questions
wanna-
for the good doctor here?
Thanks.
Thank you, sir. Anybody else going to testify? All right, both the chairmen had to leave. They had meetings at 2:30. Number 27, we got a question down here.
Proper time.
All right, let's see any other questions from the committee, from anybody that spoke? Because we're getting close to our time limit that we call. All right, no one else, no hands raised. Hearts are clear, hearts and minds are clear. All right, number 27.
Thank you, Mr. Chairman. I'd like to make a motion this House accepts LC 337012S as a committee substitute.
And that's the due pass recommendation.
With a due pass recommendation.
Got a second by Chairman Harrell. All right, questions? Okay, time for the vote. All in favor, let it be known by saying aye. Aye. Any opposed, like sign? Yes. No. All right, let's do a show of hands. I think I've got 3 there. All in favor, let me know by raising your hand. You get a count. All right. Opposed, like sign. All right, motion's passed, and we are adjourned. Thank you very much.